We had my parents helping out initially. As I was navigating, I was in 2013, I had to sit down for my oral boards. So for the first 6 months of Harrison's life, I was taking care of him, working full time, and then studying for boards. So my mom and dad, basically, they literally lived at our house.
You're listening to the Mommy Labor Nurse podcast, where you'll gain the knowledge and confidence you need to erase the unknowns of pregnancy and birth and rock the newborn days like a boss. My name is Liesl Teen. I'm a fellow mom, labor and delivery nurse, and your host. Each week on this podcast, you'll hear a mix of birth stories, expert interviews, and other fun pregnancy and birth-related content. As a reminder, anything you hear on this podcast is not medical advice. Please see mommylabornurse.com/disclaimer for more details. And now let's get into this week's episode.
Hi guys, happy Monday. Okay, so what do TikTok and anesthesia have in common? Do you know? Well, nothing really, unless you're my friend Maggie, who joined me for this week's episode. Dr. Magnolia Printz is a board-certified anesthesiologist from Wisconsin. And at the time of this recording, she had over 800,000 followers on TikTok, but I bet when this airs, she'll have close to 1 million. On her page, she shares everything from evidence-based info about anesthesia and epidurals to family life, and will even jump in front of the camera for a TikTok dance or two. In this episode, I sat down with Maggie and we chatted about all things anesthesia, especially as it relates to birth. You'll learn more about epidurals, what it's like to have a spinal placed, her call rotations, and so much more. It was so refreshing to get to sit down with someone who places epidurals and assists with anesthesia in the OR during every single shift. She really knows her stuff, and that's exactly why I wanted to bring her on the show. So without further ado, let's chat with Maggie about all things anesthesia.
Wondering what you need to do to stay on track during each week of pregnancy? Not sure what you need to be learning or researching along the way? I can help. Sign up for our free weekly pregnancy series to get tips, advice, and resources tailored to your exact week of pregnancy sent straight to your inbox every week. Sign up at mommylabornurse.com/IamPregnant to get your first email today. See you in your inbox real soon. Hi, Maggie. Welcome to the Mommy Labor Nurse podcast. Thanks so much for being here today.
Thank you so much, Liesl, for having me. It's a pleasure.
Yeah. So, Maggie, can you start by telling our listeners a little bit about yourself and what you kind of do on social media? Because I know you are on social media like I am. So what you kind of do and what your background is and who are you? I said it in the intro, what we're going to be talking about today, but if you could just introduce yourself, that would be lovely.
Sure. I am Magnolia Printz. Most people call me Maggie. I'm a board-certified anesthesiologist. I'm in private practice in southeastern Wisconsin. I am also a mom of 4 children, married to another physician. He's an orthopedic surgeon. And one of the main things that I do on social media is just kind of debunking a lot of the myths and misinformation that we see that tend to go viral on social media. And so my job is to kind of debunk all of those things, show the evidence behind why I'm, choosing the opposite stance, and also just encouraging people to continue to look further into these myths. Also, just on another off-brand thing, not off-brand, but on another side note, I'm also there to kind of just have a behind the scenes look on what it's like to be a physician, what it's like to be a physician married to another physician, what it's like to be a woman in medicine, all of the crazy things that go on with it.
I love it. I love it. Let's start off with that. I know I didn't ask you this in the intro, but what is it like being married to another physician? Like, what are your time? Like, do you guys work at the same time, or does one of you work night shift or one of you work day shift, or like, what is that even like?
I mean, I always make the joke that our life is like a goat rodeo. Yeah. I mean, to be honest, he is an orthopedic surgeon. He works full-time, and full-time for private practice orthopedic surgeons range anywhere from 60 to 70 hours. And that's just on his choice. And people don't understand that it's not just surgery, but there's a lot of, paperwork that needs to be done, dictations that need to be completed and notes that he has to finish up. I mean, I would say like 2 weeks ago, he stayed up till 2 a.m. finishing up a stack of notes. And like people don't consider that. That's on his own time.
Yeah.
I used to work full time, and full time for my private practice group was 60 to 65 hours.
Ooh.
And we just hit a point where we're just like, we can't do this. Somebody needs to be home. And so my schedule now is I'm a part-time for my group. And so I'm 1 week on and 1 week off. And when I'm on, I'm on. I take all the calls, all the lates, all the cases.
Mm-hmm.
And when I'm off, I have that week off to be with the kids, do all the household things, do all the errands, the appointments, all of that stuff, and manage the household. We could not do this without my amazing or our amazing nanny. She is the unicorn. She is the super glue to our household. And she actually communicates a lot of the times, like John said this, is that, is this what actually is going on? Or Maggie said this, and she actually kind of puts it together and like keeps us running like a well-oiled machine.
I love it.
So she's the glue.
Really,
she is our super glue. We could not live without her. And I tell her all the time, I don't care if my kids are in high school or going off to college, you are staying with us.
You're going to be my fifth child, right? Like,
exactly.
I'm just going to adopt you.
No, she is
family.
like my wife. Like, she's my wife.
Nice.
Like, seriously, she is the best. But yeah, it comes with its own challenges, definitely in terms of like juggling the schedule. But, in terms of like what we talk about, obviously without breaking HIPAA, we can vent to each other and understand where the other person is coming from. I'm more understanding of his late nights and things like that. So there are advantages to that, for sure.
Yeah, no, I'm sure. My husband is not medical at all. Like he's in sales. He does, that like very, very non-medical, and he's very squeamish with everything. So like, I can't talk to him about, like, I have other friends that I vent to and other medical friends really that I vent to about that sort of thing. But like me and my husband do not. She's like, no, I don't want to hear anything. And I'm like, it's okay. I'll talk to Jenna about it, or I'll talk to Tiffany about it.
Yeah.
So,
he'll just sit there and like, just let me vent, which is really nice. He gets it. Cool,
I want to talk about social media really quick. Cause like you said in the intro, you are all about, you're on TikTok. I said it in the intro to you before we started recording that I've been following you on TikTok for a while, and I love your TikToks. So I want to know, now that Instagram's starting to, have this more of a real format and they're starting to be TikTok, what do you prefer? Do you still love TikTok, or are you starting to get into Instagram? Or you like both of them?
I'm probably going to get hate. I love TikTok. I do.
I do too.
It's just so much easier. There's not as much pressure to be perfect. You can, put out a message like really quickly if you want to. Like sometimes I'm like in my pajamas and I'm like, oh, I want to do this, or like, I want to talk about this, and I do it. Where I feel like, writing out, like, especially before Instagram was focusing on reels, like writing out paragraphs
oh my gosh,
of things. I'm like, someone's going to be a grammar police and I'm going to make a mistake. And, it just seems like the TikTok audience, maybe because it's a younger demographic, they're more forgiving. Yeah. Also, and don't even get me started on Twitter. I want to delete my Twitter account because like, I'm
not even on Twitter. I can't.
It just seems such a mean, and some of my colleagues are on there and they really, really like it. And, I just think it's the way you consume media. And like, for me, it just seems like a really mean-spirited place, and I just don't need that energy. Yeah. And I feel like over any little thing, you'll get nitpicked. And I'm like, I can't do that. Like, it just hurts my heart. So I prefer TikTok just because it's ease. And it seems to be, things tend to get more views than Instagram for sure. That's the place to be.
It's way easier to go viral and just get followers and, just like share your message for sure. I've had weird videos like get tons and tons of views, and I don't even have that many followers on there. Like I just kind of post stuff that I would post on Instagram, but it's like one of them will do randomly really, really well. So yeah, I'm a big fan of TikTok too. I'm starting to like, as other people who work for me do other things, I'm starting to like be able to devote a little bit more time on TikTok. So I like it. It's fun. Like you said, it's easy to get your message out there and just be in front of the camera. So, well, I want to know why you got into anesthesia, because, when you go to, I'm sure you go to medical school, like any other physician, right? Right. So what made you get interested in specifically anesthesia, and what was your schooling like? What was like your residency like after med school?
Okay. That's a 3-part question. So I'm going to
Okay.
write parts of those down.
Okay.
So the first part is, why did I pick anesthesia?
Yes.
So during our 3rd year rotations, and I did medical school at the University of Wisconsin, so not far from where I practice now, but you go through every major area, pediatrics, general surgery, and all of the things that, get a good knowledge base of what it's like to be a doctor in all these different fields. And anesthesia was actually my last rotation. And it was something that I was not even remotely considering, because I hate to say it, I had some preconceived notion of what anesthesiologists actually do.
Yeah, like they don't like patients and they only put people to sleep. And
exactly. They're just like sitting there, rolling their eyes and not paying attention to the stock market and not really being engaged, and they don't like patients or whatever. So I also had that stereotype in my head. But every rotation that I did as a 3rd year, I went out of that rotation being like, wow, that's so interesting. Like I could see myself doing that. But it wasn't until I got into my anesthesia rotation where I was like, wow, I really feel like these are my people. Yeah, the people that I made fun of and said that they just sat there and looked at the stock market or were just, on their reading a book and not paying attention. I think it's because we make it look really easy. And the people that go into it, I don't know, they're just some of the coolest people. So it really was more of a feeling. Mm-hmm. And I loved being in the operating room. But I did not want to be a surgeon. Mm-hmm. I really love procedures. I don't really like clinics that much. So that was another thing. But I really love talking to people. I mean, think about it. I have 2 minutes to get someone's trust.
Yeah.
And to have them trust me. And they literally okay, I trust you. You can go ahead and basically cease all bodily functions and take over while they're cutting me open. Yeah. And then I expect that you are going to revive me and, take care of me in 2 minutes.
Yeah,
exactly.
Yeah.
So that's kind of cool. You do need to have really good bedside manner in order to be able to do that job well. And to also people are in a very vulnerable spot when they're in labor or when they're about to have surgery. Yeah. And it's an honor for me. It's really a privilege that I can take some of that worry away. And what I tell all my patients is, you are not paid to worry. I am. Give me all your worries. Believe me, I have plans A through G. I have a plan for this. If this happens and this happens, that is my job. Yeah. Please let me do the worrying for you. So what was my med school like? I mean, it was shocking. It was a total oh my God, I did not expect it was going to be this challenging.
Okay.
I mean, I really did enter a state of depression in between my 2nd and 3rd year. I'm not even going to sugarcoat it. It was crazy. It's so competitive. The amount of knowledge that they expect you to have in a short amount of time is just insane to me sometimes. And medicine is always evolving. So there's new studies and new landmark things that we have to learn about. I mean, even my partners now who graduated in the 90s or late 80s and early 90s, they had to relearn how to do nerve blocks using ultrasound because they didn't have it back then. So I'm sure there's going to be a big change when I'm, in my 50s and 60s.
Something.
Something. And residency it was fun. The days and the nights were long, but the years went fast. Yeah. Because we were just so busy.
And did you have kids? When did you start having kids?
I waited until my husband was done with residency before we started, really trying. So I graduated in 2012 and from residency, and then I did a 1-year fellowship and actually became pregnant towards the middle of it. Okay. And then had Harrison, my 2nd oldest, because we adopted our oldest in April of 2013. And then I was living in Wisconsin for a while, and John had to finish the last, month of residency. Mm-hmm. So I kind of waited. And one of the reasons why is because we didn't have family in Michigan.
Yeah, that's tough.
It's so tough. And to be part of a 2-physician household and not have support would have just been very overwhelming.
So when did your nanny start? Back then, or did you have?
So we had my parents helping out initially. As I was navigating, I was in 2013, I had to sit down for my oral boards. Mm-hmm. So for the first 6 months of Harrison's life, I was taking care of him, working full time, and then studying for boards. So my mom and dad, they literally lived at our house. And then after my boards were done, that's when I started focusing on trying to find, permanent childcare. Yeah. And our unicorn nanny is our 3rd nanny, but she's been with us for almost 3 years. And the other ones, they just lasted a year. And not that there was anything bad with them. It was just like, it wasn't a perfect fit.
Yeah. Yeah.
And that's okay. It's so tough.
You got to find the right person for you, and they have to find the right family for them.
Exactly.
So, yeah.
And when you have the right one, because it's like, they're like family. And like Amy, our nanny, she's family. Yeah. She is family. So
yeah. That's amazing. All right. Well, I want to talk about C-sections and epidurals today. Okay. Because those are like the primary things that mamas that listen to this podcast are concerned about. So let's start with C-sections.
Sure.
Can you run through like your primary role if a mom is having a C-section? I want to talk about scheduled C-sections. And then what if you get a call from the charge nurse, them saying we're going back to the OR? What does that process look like?
Oh, yeah. And they're completely different.
Let's go through
it. And I don't know if you know this about me, but I've had 3 C-sections myself. Okay. So I feel like I'm kind of intimately aware of what it's like to be the patient and then what it's like to be on the other side.
Yeah.
So when it's a scheduled C-section, for whatever reason, things are all way smoother. And just comparing my first C-section, which was unplanned, versus my second one, I decided to just do a planned C-section. It was night and day.
Yeah.
So scheduled C-section, usually I'm in private practice. We have a physician only model. So I don't have an assistant or CRNA or AA with me.
Okay.
So I meet the patient usually 30 to 40 minutes before they're about to go back to the operating room. I go over their medical history, do my physical exam, and then explain what my role is and what I will be doing for them. And when it's scheduled, 99% of the time, we're going to go ahead with a spinal unless there is a contraindication to it. And at our hospital, we then, for me, for a scheduled one, I'm in the room setting up as the nurses bring the scheduled C-section patient back. And that's where we do the spinal. And the spinal itself literally will take 1 to 2 minutes, but it's the setup. Everything has to be sterile gloves. Your back is sterilized with the cleaning solution. I do have an anesthesia tech that helps me with positioning, and the nurses help me with that too, and all the monitors and whatnot. And I usually try to ask the patient, I'm like, how much detail do you want? Do you want me to go through every single step with you? Because some people are like, I don't want to know, just tell me when you're going to poke me. And others are like, yes, I want to know. And so I just kind of get a feel for that. And I usually just try to lighten because it's a scheduled one, they've probably already had one before. So they kind of know what to expect. So I'm asking them about nursery themes and things like that.
Other things.
Just trying to get their mind off of it. So once the actual spinal is done, we lay them back down. We make sure that all the monitors are back on. And I'm there the entire time, from the minute you are in the room to when I deliver you to PACU. I basically don't leave. But why am I there, right? Like, the spinal's working. Everything should be good, right? Like, why do I need to stay? There's, the OB who's operating. Well, here's the thing. As with anything with medicine, there are side effects. So a lot of my job is making sure that the patient has hemodynamic stability, that your heart rate is good, that your blood pressure is good, that you're not feeling nauseated from the spinal, and that you're not having, areas of patchiness because the spinal, has this little area that it didn't cover, or the spinal may not have gone high enough. So what do you do then? Or the spinal may not work because, it does have a quick onset, but for there's when we lie them down to the prep time and everything, and we're testing levels, and we just trust that it's going to get to a certain level. And we get what I mean by checking the level is the dermatomes. We just want to make sure that it's risen appropriately. But there are times like the dermatomes are fine, but, they may still feel a little, discomfort. And then we have to address that. So I'm there chatting them up, making sure they're comfortable, taking care of any side effects, maintaining hemodynamics, and assisting the OBGYN with anything they need to, and there because of emergencies. We expect that everything goes smoothly, but if it doesn't, I'm there. I give blood, I put in more IVs, I help with the baby. Anything.
Just in case, or if they have to, and if they have to go under general really quick for some reason, you're there. Yeah. So what about when the procedure is complete, like getting into PACU? I know that's usually, so at my hospital, we have CRNAs, so we communicate more with the CRNAs as they're bringing us to PACU. So what is your role then bringing them out to PACU?
So what I do when I bring them out to PACU is I make sure that they are completely stable, right? all their vitals are good, make sure they're, not complaining of any symptoms like of what we worry about, the local anesthetic systemic toxicity, because that could present even later than, the initial dose of that spinal. We want to make sure that the spinal hasn't gone too high. Like, oh my gosh, my fingers are all numb now for some reason. So hemodynamic stability, their temperature is good, baby's good, they're not nauseated, they don't have a headache. And usually I stay with them for about 10, 15 minutes along with the labor and delivery nurse. And then I sign out, obviously, during that time too, all the meds that I gave them. And then my job after I sign out is then to go make sure that, if there's any other C-sections to do or any other epidurals to do. What we do at our hospitals, we take 24-hour in-house, OB calls. So we are there 24 hours, and our group is there 24 hours, 7 days a week, 365. So I'm basically, in charge of all the other patients that need anesthetic services.
So in the hospital that I work at, it's similar where they don't do 24-hour call, but they do different shifts.
Sure.
But especially like on the weekends, there's only like one of them for like the whole hospital. So is that Correct. How you guys do too?
Yes. Okay. There's only one of us. And so if there's a slow period on OB and I'm never going to say that when I'm there. Okay. I'm sorry for those people on OB called out, right? I just said the S word. I won't say the Q word, but we are also called down into our emergency room for regional blocks, intubations. We're called down to our ICU very often for intubations and central lines and arterial lines and, any kind of management that they need, especially with COVID and whatnot. But there is another person on call at our hospital on anesthesia that is just for the operating rooms too. So my job when I'm on OB call is OB first. It's literally like if somebody has something going on, I'm in an epidural or I'm in a C-section case, I'm like, sorry, go find somebody else or go call the first call person or the second call person. I am tied to OB. And I think that's appropriate because as you know, things in OB can quickly.
Woo! Yeah, baby goes like this. Woo! Let's go back real quick.
Quickly. And that's getting back to the second part of what happens. Yeah. What happens when there is a emergency C-section? And that's when literally that is a goat rodeo. That is a goat rodeo. We have the operating room always set for an emergency C-section. Every morning that I get there at 7 a.m., or actually before that, because I need to get signed out and I'm getting the other anesthesiologists out. I'm pulling up, not drawing them, but I'm getting the drugs ready for an emergency C-section because I'm basically planning for a general anesthetic, especially if it's a crash. So I'm getting my tubes ready, my laryngoscope ready, all the drugs ready, all of it's ready to go. Even if there's nobody on the OB floor, that is, I don't care because if I don't set it up.
You never know who's going to be coming wheeling into triage with a prolapse cord or something hanging out. Yeah,
exactly. I am asking for it. If I don't, I also have, I usually check to see who also is on first call and second call. And I have their numbers on speed dial because the minute they call me there, I'm in the patient's room. And so the minute they call, the charge nurse calls, I'm in the patient's room and I don't leave their side. I already have drugs in my back pocket also, like the local anesthetic to slam in because this time is so key, right? To get that baby out safely. So I am numbing them up as we're being wheeled back into the operating room if they have an existing epidural.
Yeah.
If it's urgent and the OB thinks we can do a spinal, we can attempt one, but I don't jack around with it. If I can't get it on the first try, I'm like, all right, you're going to sleep.
Yeah.
And the worry before in the past was difficult airway because of progesterone and all the hormones. You have airway swelling and you get these breasts that are, because you're going to probably have milk coming in soon. So they're kind of up by the neck and you're just before that was an issue. I think now with the video laryngoscopes that we have, that has become less and less of an issue.
Oh, that's interesting.
We still have to do rapid sequence, intubation because you have this big baby pushing up on the stomach, even if you haven't eaten. But a lot of these people can come off the streets and they just had something to eat. So it's still, cricoid pressure, rapid sequence. But I don't find that difficult intubation is that as much of a worry as it used to be in the past. But if we want to get the baby out quickly, it's definitely GA if they don't have an existing epidural.
Yeah. Yeah. Go.
Yeah.
Well, you mentioned that you don't work with CRNAs, but have you ever worked with CRNAs in the past? And do you feel like you can touch on what a CRNA would do versus what a general like an anesthesiologist would do?
In terms of the situations?
So like in a C-section, I know, usually the anesthesiologist comes in and does the spinal and then the CRNA kind of monitors.
And I guess it depends on what kind of like C-section we're talking about.
True.
If it's true. But to answer your first question, yes, I have worked with CRNAs. I think they're fantastic. I think they're a great adjunct and like they're valuable. They're so valuable to the healthcare team. And they obviously make my job a lot easier too. But then they do put on more responsibility because if you're paired up with a CRNA, that means you also have more rooms to cover. If it's a routine C-section that is planned and scheduled, usually what happens is, yes, I place a spinal. I, sign out with the CRNA. They're there during the entire case. I'm usually there I usually come back, periodically to make sure that everything's going well. But our surgeons are so fast, they're done in like 45 minutes. So sometimes it can take longer. I'm usually there at the end and I help drop them off to PACU, talk with the patient again. But before the spinal is placed, I'm there with the CRNA, consenting them, going over their medical history, coming up with a plan. Yeah. If it is a goat rodeo, no, all hands on deck. It's a
term,
crash.
Goat rodeo. I'm going to write that down.
It's seriously, it is all hands on deck. We manage the patient together and if it's a crash, I'm not leaving because it's usually there's something else going on. Yeah. And I want to be there when the baby's delivered because I may need to help with that baby. Mm-hmm. And we have great NICU too. I never want to get in their way. They know what they're doing, but there's always that possibility. So I never leave the room because it's like the more hands on deck, especially for a crash, I'm not messing around. Yeah. Yeah. So I usually sign out my other cases that are going on to another anesthesia. Like I had done that when I had worked with CRNA, sign out to another anesthesiologist to pick up the extra cases. Yeah. While I'm in the crash season.
All right. The sound of that baby crying means it's time for this week's segment of Birth It Up Babies. So this Birth It Up baby is from Instagram. She says, "Hi, I just wanted to let you know that I took your natural series course back in February. I was so afraid of labor. I was present during my sister's unmedicated birth 4 years prior and got traumatized. Best birth control ever, LOL. But even so, I was determined to do an unmedicated birth, but also wanted to know my options in case I changed my mind. I was feeling lots of anxiety towards the end of my pregnancy, but after taking your course, I felt much more at ease. I kept thinking to myself, I can do anything for 10 seconds. Yes, that is something that we definitely teach in the natural series. And that helped so much. I had my baby girl on March 15th, completely unmedicated. Thank you so much for all you do." Oh, that one is such a good one. If you want to check out the course that she took Birth It Up, the natural series, and you can head over to mommylabornurse.com and click on the natural series. All right, let's get right back into this week's episode.
All right, so let's transition now and talk about epidurals because that's like kind of the other, big role that you do, when you see OB patients. Sure. So I've talked about it on here before on the podcast, and I have a whole blog article and in our birth courses, I talk about in detail, like what is getting an epidural like and what is the placement like and what is the procedure like. So people know it from a nurse's perspective, but do you mind sharing from your perspective? Sure. Like if somebody, if I say, "Hey, Dr. Printz, my patient in room 4 needs an epidural. Her platelets are good. She has had one before." Then what do you do?
So after I get the phone call, what I do is obviously Epic and electronic medical record. Yeah. Before I go into the patient's room, I want to make sure that I know what I'm talking about. So I look over their medical history and make sure that there aren't any other contraindications to an epidural, because platelets is definitely one consideration, but some people are on blood thinners, and when did they last stop?
They need
right. Yeah. When did they last stop their blood thinners? Caveat too, some people worry about aspirin. We can place epidurals when a person's on aspirin. Some people have had back surgery before. Where is the incision? Where are all the, rods placed? Was the dura breached during the surgical, during their surgery? What levels are we working at? Is there a baclofen pump? You just want to make sure that there are no major red flags where we have to actually sit down beforehand. And our OB group is really good about coming to us and be like, "Hey, we think this person needs an anesthesia consult. 10 or 15 weeks prior to delivery so we can have a plan and everybody is on the same page. Because like I said, we have a different anesthesiologist every 24 hours. Practices may vary. One person may be comfortable with one thing, another person may not be. So we have to have a plan. So I look up the patient, look at their labs, look at any prior, we have labor epidural notes, like what anesthesiologists have done in the past, how deep was it, what level was it, what med did they use, all of that stuff. So I go in there and I'm like, all right, I have a pretty firm grasp about this patient. And then I just review it with them. And then, about their medical history. Do my physical exam, which includes the airway exam. When people are like, why are you asking me to say, I'm like, I want to make sure that your airway's good.
Yeah.
And then I take a look at their back, make sure there's no like crazy scoliosis or back curvature. And then, we sign the permission slip and then we go ahead with the actual procedure itself. With informed consent, I go over, obviously the benefit is that they're going to have reduced sensation of labor contractions. I always kind of warn them that, the way that we do epidurals now versus the way they did them in the 1980s, those are really heavy-handed. Women could not feel much of anything. Yeah. The way that we dose them now, women will feel more of a sensation like, oh, okay, but you can nap through them. Okay. Like you can take a nap, but you'll still feel your contractions a little bit. So that's obviously the greatest benefit, but there are side effects. Like, let's not, sugarcoat this. With any medical procedure, any treatment, there's always going to be side effects. Yeah. One of the major things that we worry about is a major drop in blood pressure. And that's why you give fluids beforehand to kind of help mitigate that. And then that major drop in blood pressure, especially for people who have heart conditions, whatever, and even normal people, that can trigger that nausea that a lot of people feel with spinals. Because it's like that blood pressure going from 130 over 60 to, 85 over 40. Oh yeah.
And you're going like that.
You're going to feel nauseated. So we usually try to give at least 500 cc's of fluid before we get that epidural going. The risk of posterior puncture headache, I talk about that. That's 1%. And that's when the epidural needle is actually kind of acting like it just breached into the dura. So you're not supposed to go into the dura. And that's a big needle. And that's what causes that headache. That's 1%. And there are other things, but the myth about back pain, we can talk about that in detail later.
Let's talk. We'll save that for the end. Later. Yeah.
We'll save that for the end. But I go over the common side effects and then we go ahead and do the procedure. My nurses are so amazing. They already have the cart pulled in there for me. And they usually have the patient position. They've already had everything bolus. I'm like, yes, this is so amazing. And then the patient doesn't have to wait for all that stuff to happen. So I usually, I coach them again through the positioning and just kind of, again, do you want to know every single step or would you like to just have the major ones? And I kind of say the biggest annoyance out of it is that big pinch, that big bee sting. And it feels like a bee sting for about 30 seconds. And that's me numbing up that area where I'm going to go.
Yeah. Right? And I tell moms, it's not because it's like a big needle. It's really the medicine that's stinging. Exactly. That's what you're feeling. Yeah.
And honestly, I tried it. And this is what I do. I try to time it with contractions. Like if they're about to have a big contraction, that's when I poke them. Yeah. Because your body has a really hard time trying to find, pain in two places at once.
Yeah.
And a lot of them are like, I didn't feel that because I was contracting so much.
That's smart.
That's good. And then after that, you got to hold still. We got to hold that position, that C curve. We want to look like that angry cat on that Halloween fence or a shrimp. And that really helps open up the vertebral body so we can get into that space. And before that even happens, it's 5 minutes of drawing up drugs. So I'm talking again, what did you name your baby? Do you want to share your baby's name? What's the nursery? What's your theme? Is this number one or number two? We talk about what it's like to be a boy mom or a girl mom, whatever. I'm just shooting the shit because this is very scary for them. But, I know I was scared, but just trying to help them with that. But the actual epidural itself usually goes in within 1 to 3 minutes, depending on, whether they have scoliosis or whatever. That can be a little tricky sometimes. And also don't be scared if the anesthesiologist asks, do you feel this in the middle or do you feel this to the left or do you feel this to the right? Because that actually helps us because that helps, the way that we actually find the space is landmarks and by feel. And so if we reach a bone at a certain depth and you say, oh, that's to the right, that's going to help me navigate that needle in the correct direction. So don't be scared that happens. That doesn't mean that anything went wrong. So once we hit into the epidural space and the way that we find that, again, it's with landmarks. And you might see us fill up a syringe with saline. And we know we're in the epidural space because then we can push that saline into that epidural space. Any other space that won't happen, except for obviously the CSF space. But that's, much further back. And once we get that in, you might feel this like really cool sensation. Once we hit that spot, that's when we thread that catheter. It's about the size of a fishing line. And I tell husbands, I let the husband stay or the partner stay.
I have one right here, actually.
Yeah, it's the size of a fishing line. Yep.
Right here.
And it's very hard.
Someone sent me one.
Oh, yes. I'm going to send you one. And, we thread that in. And I always tell the person, because I have the partners usually holding the patient's hand or whatever. I'm like, just make sure to move out of the way because this can make them kick you. Because it sends that electrical shock through. And that's because that catheter is tickling up against the nerves. And that can send that electrical zap. And it hasn't happened that often, but that it can happen.
I've gotten kicked at like 3 times, I think. Okay.
In your entire career, that's not bad.
It's not bad.
It's not bad. And some people don't even really feel the zings, or it's very temporary. And it does go away it does go away. And then we do what's called the test dose. Now the test dose, the reason why that's important is number one, we want to make sure that that epidural catheter is exactly where it's supposed to be, that it's not in the CSF space, which then it would act like a spinal, or that it's not in a blood vessel. So there are actually 2 things inside that test dose. And we say test dose because it's a small dose that we give through that catheter. And one of the medications in that test dose is epinephrine, because if it was in a blood vessel, epinephrine through a blood vessel, that's why we ask you, do you feel like your heart's racing? We monitor your heart and we get a baseline, because if that heart rate starts shooting up, that epidural catheter is in a blood vessel and we don't want that. So then we have to redo it. Okay.
No, thanks.
No, thank you. The other thing that we ask is, do your toes or your bottom suddenly get numb and heavy? And we do that test dose because, again, if it's in the CSF, it's going to act like a spinal, and not much of that test dose is, you don't need much of that medicine in order to cause that, sudden, dense feeling. Epidurals take 10 to 15 minutes for full effect. They start at the feet with warmth and tingling, and then they just slowly climb up. Whereas a spinal, it's like within 2 minutes, you're going to know that it's working. So that test dose is super important to do to make sure. And once they pass that test, we tape it all up. The way that I tape it is, if you have that little catheter going out, I have steri strips and I actually make a hashtag with it like this.
Oh, cute.
And I'm like, hashtag epidural. And people think it's hilarious, especially my millennials. I'm like, you can take a picture of it and post it on Instagram with the hashtag there. Don't tag me though. But if you want to, you can. You don't have to.
I love that.
And then with that epidural catheter that's just, sitting there, we then hook that up to our epidural pump. And that has the local anesthetic and the low dose narcotic. And when I say low dose, it's like super low dose. It's way lower than any of the doses you would get IV. Okay. And as long as that infusion is running and that medicine is being delivered into the epidural space, the women are usually pretty comfortable. We do expect that as the baby descends further down the birth canal, that the labor epidural may not seem as effective, and especially when they're, you enter the second stage, a lot of women don't get the lower coverage, like L3, L4, L5, S1. And that's where we call it the ring of fire for a reason.
Yeah.
And it's not because we turn the epidural off or it's not working. It's literally because of your anatomy, and the epidural is just not getting to that area. And I always just kind of warn them that may happen and that you're really close to having a baby. Other things about it. So I'm usually there, for 10 to 15 minutes after, along with the labor nurse, 10 to 15 minutes after, to make sure that we have good coverage and that their blood pressure hasn't dropped too much, or that their heart rate doesn't start picking up crazy, because epidural catheters can move, and that they're getting good, pain control in the 10, 15 minute, time that I'm there. And then, like I said, the pump's set to a certain rate. You might have certain hospitals will have pumps where you can bolus yourself, or you may have to ask your nurse for a bolus. It really depends on, what kind of pumps they have. But we set a basal dose, like a dose that's continuously running in the background, and patients can sleep. Patients can sleep through that. Yeah. It's really great. We love it. Yeah. And at our hospital, we our nurses turn our patients every 1 to 2 hours, because as you know, it works by gravity. If one side's getting numb, we got to turn you to make sure that the other side's getting equal treatment. And I'm there for troubleshooting. Let's say there's the epidural it was working before and now it's not working. So I want to make sure it's not dislodged. Sometimes the epidural space in some women is really large and we might have to give extra boluses to get that coverage, and that's okay. Everybody's anatomy is just a little bit different. So I'm always on hand to kind of troubleshoot those things. Yeah. Sometimes it's easy as there was a disconnection, up top, and then it's like, all right, then we have to kind of address that. And whatever. Sometimes people need, a higher basal dose, and that's okay. That's exactly why we're there. You can't just set it and forget it with epidurals. You have to constantly be on it. And that's part of the game.
Yeah. So at my hospital, we just get an order and we manipulate the pump. Do you guys control the pump, or do your nurses control the pump?
So we control the pumps. We allow the patient controlled bolus though.
Yeah.
If we need to give a stronger bolus, so it's 1/8% bupivacaine. So that's like really pretty weak sauce, I think.
Yeah.
But if some women, it's lighter, a lot of people do fantastic with that. And I run that at a rate of 10 cc's an hour. But no, our nurses, unfortunately, I wish sometimes they can reprogram, because I'm like, can you just increase it by 2?
I know.
No, you have to go over here. Okay, fine. Over there.
I know. And no, it's weird how some places we're allowed to, but then I don't know if it's a state thing, or I don't know if it's a hospital thing, but
it's probably a hospital policy.
Probably.
The pump for us is the nurses aren't allowed to really program it. So I have to do all the rate increases. And then if I want to give 0.25%, which bupivacaine, which is a higher concentration for someone who, I want to make sure that it's working well and that hasn't, or I want to do a test with 2% lidocaine, I have to bolus those myself, which obviously makes sense. But there have been times where that comes in really inconvenient, because I'm in the middle of a C-section. None of my partners are available because they're in cases downstairs. And all they really want to do is give a bolus, and they have to wait. And it's like, really? Yeah. So a lot of the times it's the OBs will step in and give a bolus if I tell them hey, I really need this to happen. Can you just do this? And fine. Yeah. There's other OB teams that are covering. So
cool. That makes sense. Well, you talked a bit about side effects, but I was wondering if you can talk about a few more. I did want to know, I do want to talk about back pain, because that's a big one.
There's also that autism one that came up too.
Yes, let's talk about that. And then I want to talk about hot spots too, because I educate on, sometimes you have a little hot spot that comes back. So what exactly, why does that happen?
By, I guess,
so I call them hot spots because it's just a little place, usually it's due to patient placement, but what the anesthesiologist, what I've been told is that the medicine, it goes into all of these nerve roots, and sometimes it just doesn't get all the way into this certain nerve root. And then you have this little bit of pain right here.
Right.
Am I off, or is that
you're not a thing? No, okay. You're not off. And you call it a hot spot. I call it a window or a patchy spot.
Okay. Yeah. Okay. Gotcha.
It's just a different way. And it probably deserves to be called a hot spot, because that's probably the pain. We're like, oh my God, what is going on here? So usually, so it's usually because, it works by, the epidural is in this, what we call a potential space. So it's not an actual space until you fill it up with something. And so it could be a volume issue. The patient may need a higher rate. It could be a concentration issue. The patient might just need a higher concentration of local anesthetic. And so what I usually do to treat those hotspots is, number one, determine that it's actually working and that we have a good level for the rest of it. And I try to figure out which side is it? And then what I do is I usually have the patient turn on that side, and that's when I can give that bolus of that super concentrated local anesthetic.
Yeah.
And that between the extra volume and the higher concentration, that will usually take care of it for most patients.
Yeah. That makes sense. And that's exactly what we do too. Okay. I know sometimes moms talk about one-sided epidurals too. Yes. Can you explain why that phenomenon happens?
Again, so it's this potential space, and you're fishing this catheter into this potential space. And, these catheters are very flexible and bendable. And with this potential space, the catheter can have a potential to kind of hook or kind of bend over to one side more so than the other. And that's how you kind of get that one-sided epidural. And that usually tends to happen when you have too much catheter in that space.
Okay.
So we usually aim for about, anywhere between 3 and 5 centimeters of catheter in the epidural space, so that you don't have that potential for that hook to kind of happen. And when that hook comes, it's it's just pointing at one one side, right? And sometimes you can overcome it with volume, but really the way to treat it is to not place another epidural, but to put on sterile gloves, sterilize it again, and pull back a little bit so that it kind of straightens that catheter out. And then you can give a little bit more volume to kind of evenly distribute things. And that's the way to treat it. You really got to pull it back.
Yeah, that makes sense.
Yeah.
All right. Well, let's talk about back pain, because I know that is one of those that, we've heard, I had an epidural with my baby and I still have back pain like years later or months later. And can you talk about like, why does this happen? Is that, are they really, caused by epidurals, or is that a myth, or is it musculoskeletal, or like, why does this even happen?
Sure.
Period.
I think that number one, I will say that there have been no studies that can definitely say that epidurals
link them together.
You can't link them together, that epidurals can cause back pain, that 17 gauge needle that I place into that epidural space is going to cause back. You think about it, it's just a small needle, right? Yeah. It's pinpoint. I could see maybe localized like pain and swelling a couple or even a week after.
Yeah.
That I expect.
Yeah.
Or a little bit of tenderness, especially if they couldn't get it on the first try and they did a level. Yeah. Now you have this patch where they've attempted twice. That's going to be sore. Let's not, but like long-term back pain where it happens, like I had an epidural and I had back pain 6 months out, a year out. That is where I'm saying I just cannot imagine. And there have been no studies that say that the epidural causes that kind of back pain. So there are a couple, and back pain itself is such a complex issue. But let me be 100% clear. Carrying a baby for 9 to 10 months, technically, 40 weeks, 40 weeks. Okay. If we get to 40 weeks and the hormones that go along with pregnancy that, give you laxity in your ligaments and that the weight of that pregnancy, and then the arch and the way that you carry yourself and the way that you waddle. And then if you have a vaginal delivery, the way that your legs are then kind of put in those stirrups and pushing for, extended amount of time. I would also say that those things could definitely contribute to long-term back pain. And so it's hard to tease out. Is it actually the 17 gauge needle that was, easily placed, no complications for the epidural? The epidural worked well, or could it be other things? Yeah. I kind of tend to be in the camp of it's probably those, the 10 months that you've been walking around with this baby and the pushing that would cause at least the long-term side effects of back pain.
Yeah, that makes total sense. So what are some of the you said blood pressure is probably the most common side effect that you see right after placement. Are there any other ones that you see?
Nausea.
Yeah.
Nausea is definitely a big one.
Yeah.
Like those are like two major ones that I see, the blood pressure drops and the nausea.
Yeah. Now, and it's usually you're vomiting because your blood pressure is dropping.
Your blood pressure dropped really fast and now you're feeling it. Here's the thing, like other things that I counsel my patients on, it can slow the pushing phase. And on average, it can slow it down by 15 minutes for most women, because even with a light-handed epidural, we can it's hard to push when you're not feeling that your contractions, And so a lot of the, the women that have epidurals or the patients that have epidurals are counting on the nurses to look at the monitor for them and say, okay, push. Yeah. Because sometimes it's hard to, so that this coordination issue can be a problem and that can extend that second stage. It's also been shown in studies to cause fevers, epidural related fevers. Yeah. Now, again, this can go on to this other whole conversation of like, does it cause C-section rates to go up? That is a whole controversial topic. But maternal fevers.
That's another whole podcast
because I was reviewing the data last night and I'm, this is what I was taught in residency and like, here are the things that are coming out now. So I had this whole spiel, but so maternal fevers are common or not common. It can happen with epidurals. So then it's like, is she feverish because she has been laboring too long, or is it because of the epidural? That's always a question that comes up. Yeah. The other minor side effects, itching from the narcotic in there, extending the first stage of labor by on average about 45 minutes, which in the long run may not even be that big of a deal because that's an extra 45 minutes that you can nap.
Yeah, totally.
Epidurals also can interfere a little bit with the oxytocin. So sometimes, as you will see, when someone has an epidural, you may need more oxytocin to augment their labor. And then that's a whole nother controversial topic about, interventions and, whatever. So whether or not it increases epidurals or do epidurals, my take on that, do epidurals cause an increase on C-section rates? It depends. And
that's what I say too.
And I don't think it has anything to do with the type of pain control a woman actually receives, but the type of hospital that they're in and their OB, right? It's their OB's practice and the hospital policies. Some women are allowed to labor for their first time for 20 hours, and some OBs are like not comfortable with that. So that's my answer to that very complicated question that I know you want to make another podcast to. So that's fine.
Yeah, no, I totally agree. And that's what we say too, is that it's tough to correlate epidural and C-section. It's easier to correlate some other interventions with C-sections, but not so much epidurals. And that is exactly what I say in my courses too, in terms of finding an OB and finding a hospital, finding an OB that you trust and that understands you and that aligns with your birth preferences,
absolutely.
Because really at the end of the day, the hospital that you deliver at makes such a huge difference. Like the hospital that I work at, we have a very, very low, like one of the lowest C-section rates in the country. Actually, it's like fantastic. 14% or something like that.
Yeah.
But the hospital down the road is like 32 or 33, which is like the national average, which if you think about it, that's the national average. But I try to explain this to, some of my friends who live there and they're like, oh no, I want to deliver at this other hospital because it seems nicer. Like they have, like different, and I'm like, but just look at like their C-section rate is this. And, if you're having a scheduled C-section, like that's fine. But if you're a first time mom and you're trying to avoid a C-section, like just look at the differences here. Like it's a very stark difference.
You can ask your OB, like, what is your C-section rate?
Exactly.
And what are your indications for it? Can I labor for a long time? If I spike a fever, what are you going to do? Are you going to blame it on the epidural or are you going to go ahead and give me a time limit? Like, what do you do? And here's the thing, like, I'm happy to educate women on this because sometimes they just don't even know what questions to ask. If you ask the right questions, you're going to find the OB that is going to be in alignment with your wishes.
Yeah. And you want an OB that is happy to answer these questions.
Absolutely. They cannot be defensive about it.
No, because that's a red flag too.
That's a red flag.
Well,
for sure.
I had one question that popped into my head while you were talking. So I want to know, mainly for me, when I explain the difference between a mom who had an epidural during labor and now she's going back to the OR, she needs an unexpected C-section. It's, like just not emergent, but we're going back and you're dosing up that epidural versus when she's getting a spinal, how the epidural goes into a different space, right? Than if you just do a pure spinal. But how do you dose up an epidural in that epidural space to make it look like a spinal? Is it just a heavier medication, I'm assuming? Or how does that, do you see what I'm saying? It's like, there's these two spaces. Like, how do I explain that to my patients, how that works?
Yeah. So we definitely do not want to. So in a spinal, okay, let's start from, I got to get through this. So spinals and epidurals fall under what we call neuraxial techniques. And that's basically when we inject local anesthetic into either the dura, which is, into the CSF, that's called the spinal. And that has sudden onset, not sudden, fast onset. Within 1 to 5 minutes, you're going to feel that spinal working. The problem with the spinal is that it wears off. Okay. And it can wear off in an hour and a half to 2 hours. And if we expect that C-section for whatever reason is going to take longer, then you're stuck with a patient that is awake and that is still being operated on. So we have to consider the length of the C-section, which OBGYN I'm operating with, because they may, have long, historically longer times. And also with the spinal, it's a much smaller dose than the actual epidural dosing, like magnitudes of 10. So for example, if I were to dose an epidural, the volume is usually 20 cc's of 2% lidocaine. And then I'll put in 100 mics of fentanyl. And that is for, if they already have a pre-existing epidural and they're just going back and it's not urgent, I give them that concoction. By the time they're being rolled back and prepped and draped, that's working. It's nice. Whereas if I'm doing a spinal, I usually use the bupivacaine, and it's a little bit heavier. They actually put glucose in it. So it kind of so it doesn't rise, because one of the things that we worry about with spinals too is you don't really have it's based on dosing, but we don't want it rise to where it causes heart issues. Like,
does the glucose make it heavier?
Yep, it's called hyperbaric. It's hyperbaric. Cool. So it kind of sits in that area where it needs to go. And I'm literally injecting at most 2.5 cc's of, this local anesthetic solution that goes into the spinal space. So yes, we never want to mix up our drugs. We never want to give the epidural dose to the spinal dose. And the reason why is, they're in different spaces, the absorption, all of that's going to be different. They act the same in that they give you numbness, but it really is, the dosing is different. The duration is different. I can always redose an epidural. If for some reason we think it's going to be a long one, we're going to do an epidural.
Gotcha.
And dose it that way. But for a routine C-section that's planned in a otherwise healthy patient, that's a spinal. They'll get it done within 2 hours.
Yeah. Cool. Cool. Yeah, that makes a lot of sense. Thank you for clarifying that. Of
course. Yeah.
Do you have any last words of advice for moms who maybe are nervous about getting anesthesia? Maybe they have a scheduled C-section coming up, or they're nervous about an epidural?
Right. I would say, and here whenever I place an epidural, number one, the patients are just so overjoyed that it wasn't as brutal as others made it seem to be. Yeah. So listen to your friends and their stories with a grain of salt, because I feel like we always, when we tell our labor stories, it's always these fantastical, like, oh my God, it was terrible. It used to be like, but a lot of them like, wow, that wasn't even that bad. Like, I don't know why I was so scared. Ask the questions. For me, asking questions just helps relieve my mind when I'm undergoing a procedure. And this is why you're around. This is why I'm around. I want to be able to educate them so they know what questions to ask. And, have a support person, have a support person there with you. And we allow that too. Yeah. It's questions, having a support, person, and asking me any questions they may have.
And following you on where can that was my last question. Where can they find you on social media?
So I am on Instagram. I am Magnolia Printz MD. That's MAGNOLIA PRINTZ. M as in Mary, D as in dog, on Instagram. And on TikTok, I am Balanced Anesthesia. And they're kind of connected together. You can find me on one by clicking on a link, and vice versa. Yeah. And I really enjoyed my time with you. And thank you for answering all these questions. I know there's a whole other things I wish we could have talked about, but this was
a lot of fun. We only have an hour. I know. We'll have to come on again.
Absolutely. I'm down for it. For it.
Well, thanks, Maggie. It was a pleasure.
Absolutely. Thanks so much.
All right, guys, that wraps up this week's episode. Thank you so much for tuning in and letting me be a part of your motherhood journey. It is truly an honor. If you like what you heard, don't forget to hit that subscribe button so you never miss an episode. And I love hearing what you guys think of the podcast. So if you're liking what you hear or you have a suggestion, I'd be so grateful if you'd go ahead and leave me a review wherever you're listening to help more mamas just like you find the show. What do you think? Are you starting to feel a little more confident about your pregnancy and birth? Well, if you want more, be sure to head on over to mommylabornurse.com/podcast for today's show notes and a library of episodes so you can keep getting educated before your upcoming birth. And while you're over there, be sure to check out the blog and learn about our online birth classes. Find it all and more over at mommylabornurse.com/podcast. See you next week, same time, same place.